Good afternoon, everybody. I'm Dr. And thank you very much to all my good friends here, Dr. Rich, who gave us an excellent talk on ACL anatomy, and Dr. Eddie, Dr. Siti, our own homegrown sports surgeon, who has given us fantastic talk on clinical evaluation of ACL injuries, and Dr. Eddie, who is from Indonesia, who gave us a fantastic talk on ACL graft selection. And of course, we were very well entertained in the end by Dr. Freddie Fu. We are grateful to him for allowing us to use his video, which we did our live demo in the APA Sports meeting in 2019. So with that, without further ado, I think we have about half an hour for panel discussion. And I see there's a lot of questions that's been asked. And I think we'll probably open the floor for questions. And I think the first question, if I'm not mistaken, in the question box was from Dr. Ong. I probably addressed to Dr. C. Do you check the medial step before the liver test?
Thank you for the question. Yeah, that's quite a good question. Yeah, we actually do check it for the Lachman test as well as the ADT, right? Of course, for liver test, we cannot reduce it because it is like using manually and the gravity actually pulls whatever is there. So because of that, the reliability and I'm talking about sensitivity and specificity is not as good as the Lachman and pivot sheet. However, because it is, I mentioned, simple, very simple to do and reproducible. So we can't really like make it reduce to get the medial step up reduced. Then before we proceed with the test. So it is basically nobody has actually done that study before. So I myself, you ask me, I don't think it is going to be feasible to do that because of the gravity pull itself. And we are using all manually, just putting the fist under the proximal tibia there before you put the force on the distal quads. So that's my answer.
Yeah, I think the evaluation of ACL injuries or it differs quite a bit. I'll just add on a bit and I'll ask the panel as well. Because I think in acute and chronic, in acute patients when it's swollen and all that, it gets a bit difficult. Chronic is a bit different. And I think you also need to examine the ACL. You have to make sure the PCL is not there. If the PCL is there, you need to neutralize your knee and then examine your ACL. You want to make sure your lateral corners, your anterior drawer and internal rotation, external rotation, you don't want to lose out your posterolateral corner. So it's quite challenging. So that's why we need the examination. You need the history of pop sound, and then, oh yeah, that's an ACL, and then your investigation helps you, and I think it's a mixture of everything. Right, Dr. Siti? Anybody, yes. Any panel got any other opinions? Any other additions? Rich or Eddie?
Yeah, well, I think more or less if it's an acute injury, normally you want to let the knee to settle down first, because if not, everything is going to be tight. All the soft tissues will be tight, will be swollen, and it's very hard to do your physical examination during this time. Yeah.
Okay. So I think the second question is very good. It's from Dr. Sheena. Which group of patient would you recommend bone tendon bone versus hamstring? I just wrote it down. I think I got the question correct. Which group of patient you will recommend bone tendon bone versus hamstring? I think we will start with Dr. Eddie for this one, and then the rest of the panel can add in.
Well, I think in every patient that I will do a ACL consultation, I will discuss the graft choice first with patients, with his job, his religion, and what's the consequences of the graft choices for her or him. And then we decide if it's not really matter for him for kneeling pain, for example. So for very active patients that need the quick return to sport, then BPTB probably be the best options. Yeah, but if you look at the literature, actually, many researchers say that actually there's only a slight difference. Maybe some systematic reviews show also no difference in option, but my preference until now still hamstrings, but in some cases that might need a very strong graft, I will choose a BPTB graft. Yeah.
Rick, any preference?
For me,
yeah,
I normally use hamstrings, but it also depends if my patient is an athlete who's a very big guy, very powerful guy, football players, and also people are really in hyperlax lax for the knee. I normally use also BTB. But of course, I still weigh the options for the patient, especially what they need most.
What about you? Which patients would you use? Bone, tendon, bone. You say, this patient, I am not going to use a hamstring. Any options? Siti, you have any patients which are like that you would not use hamstring? You say you will prefer bone, tendon, bone?
I guess everybody would agree that the use of BPTB is commonly offered for those with high demand athletes, no? However, there are certain types of sporting activities or certain types of athletes that we may have to consider not using the BPTB. So you ask me, those who actually involve jumpers, talking about high jumpers, talking about any activities that involve jumping, means high jumpers, you have long jumpers. Basically, hamstring itself is a very important structure for them to do these activities. So whenever I have patients who have these activities as part of their important daily like sporting activity, so I would consider BPTB not strictly, strongly consider BPTB rather than taking the hamstring. Of course, in any other sport activities, Dr. Rich had mentioned about soccer or football. Yeah, definitely. Anybody with high demand activities like that, we would consider BPTB rather than hamstring. It's all because of the I would say faster, not faster rehab, it's a faster healing because of the bone plaque itself. But at the end of the day, we are talking about long-term results, of which both of them have similar outcome.
Okay, thanks. Very good answer. Let me add into one other subset of groups. In my hands, I will not use hamstring in patients who have MCL injuries. I will not use hamstring for patients who have cross ricovatum, especially in a cross ricovatum, unforgiving knees. I will tend to use more bone, tendon, bone. Our patient with MCL injury, because hamstring are the secondary medial stabilizers. So in this group of patients, I tend to err towards bone, tendon, bone. This is another subset apart from all the reasons mentioned, like bone-to-bone healing and all that. So let's go on to the next question. I think this will go predominantly to Eddie and Siti, I think. What are the choice of grafts in sprinting, Eddie? Your choice of graft in sprinting, patients who want to sprint, want to be a Rabuan Pitt and Usain Bolt.
Yeah, for sprinting athlete, you use. I think again we have to discuss again with the patients, with short-term and long-term results. And for sprinting itself, and you see, I still prefer to do using the hamstring tendon for sprinting. I don't think it's really a problem for because you know that you have a sprinting and you have to put a lot of force in your anterior knee when you sprint, and so I prefer to do a hamstring tendon for sprinting. I don't know what's your preference.
Siti, any comments, Siti?
Again, we're talking about sprinters here. They come under the high demand athlete. So of course, also needs the hamstring as well. But this is the dilemma usually when we actually want to decide whether we want to offer BPTB or the hamstring. However, again, if let's say, for me, if let's say there is no patellofemoral issues, I would still consider doing BPTB rather than hamstring graft. So I would still offer unless the patient has got existing patellofemoral issues for sprinters. Yes.
Thank you for the answers. Let's go on to the next question because we have quite a bit of questions here. So question number 4 from Dr. Faisal. What is, I think, unfortunately, most of the questions are graphs. What is the difference in the terms of IPDC score after 2 years among all types of autograft and allograft tendon used in ACL reconstruction? I think it's a very broad question. So basically, I think they're asking which graphs score better in terms of autograft and allograft after 2 years. I think again you'll go back to Eddie first.
Well, I think we look at the type of the graft. I never use allograft for to be honest, because it's availability. But if you look at the literature for young patients, active patients, I think the choice is autograft for sure. The result so far is about the same for long-term follow-up, but for midterm and for short-term or midterm follow-up, about the same. If you use a non-irradiated allograft, but you use but the long-term result seems to be that the autograft is much better than allograft. Yeah.
Rich, any comments?
Yeah, personally, I don't use allograft because it's very inferior to the autograft. At the same time, just a comment with the hamstrings with the sprinters. As Eddie said earlier, like in 6 months, the hamstrings regenerate. At the same time, I think it boils down on the rehab and the proper conditioning afterwards. Because all our athletes, like sprinters, football players, we never have any weakness in the hamstrings. So post-op rehab and conditioning is very important in this.
Oh, thank you for the answers. To be honest, me too. My options is finally. I mean, talking about the IKD scores, I generally feel, in my experience, autographs always fare better. I only use allograft when there's multi-ligaments to be involved, and if I need to revise from hamstring, I use a PTB. From PTB, I use a hamstring, and I always tend to put in the joint something which is autograft rather than allograft because I think they fare better. But if I need to, I use allograft. But the IQDC scores after 2 years, often I don't really have any figures to put it forward. But I generally feel in the literature, autographs generally do fare better than allografts as far as the literature is concerned on a general. So let's move forward to our next question. This question is from Dr. Sivalingam. It's a very interesting topic. He is asked, what's your opinion with hybrid graft fixation, such as neoligament when the graft diameter is small? So basically the question is, would you combine, you put a neoligament or a synthetic graft together with an autograft, and especially when your graft is small? Let's direct this question to Rich first.
Well, normally, like Asians, we normally have smaller grafts than compared to Caucasians. Okay, but for me, lately, for the past few years, maybe 5 years, I've been using double buttons on the femur and in the tibia. I never have a 6 millimeter graft. My average graft is around 8 to 9. So that's because we do a quadruple, and I just use semitendinosus. But the problem, if there's a small graft, then you can actually get that gracilis. So I think it would make it thicker.
Now the question is, would you consider a neoligament or not?
Well, just in case you can actually, if you have no other choice, you can. But if you want to augment, you might as well. There are other options you can actually get. Yeah, if considering you're using both semity and gracilis, and then you use a new ligament to augment it, I think that's fine. But it depends also on the activity of the person.
Okay.
Yeah. If the person's big, strong, and athlete, I'd rather get a real autograft than get another one.
What is your concern? You're worried about something, or?
It might not be that strong. If it's a big, like for example, like a big 6'3" guy playing soccer or basketball player who really needs to, who's really active and competitive, you really want it strong. So, for me, the autograft is actually much, much better.
Your views on your hybrid fixation, neoligament and autograft?
Okay. generally neo ligament that have been in the market right now have been like of poorly rated because of the complications, I would say, and reactions. However, there is I would say one type of new ligament. Have you heard of Athlon? That has a different mechanism. So this has been actually recommended as to be used as in isolation or to be used in combination. And if you ask me, I've never have to use it for ACL or for primary ACL reconstruction though. However, if you to go deeper into the mechanism of how this synthetic ligament is stimulating regeneration of cells, it's like a scaffold. So it sounds to me like it's gonna complement the autograft. As we know, majority of patients either autograft or allograft biological reconstruction actually does carry and slightly less outcome as not even grade, not really grade 0 as what we expect it to be. Of course, they are asymptomatic most of the time, but we want it from grade 1 becomes grade 0. So possibility is that this particular hybrid technique would be possible to improve the outcome in ACL reconstruction. However, we have yet to wait for I would say further studies in order to get evidence-based, I would say, rather than trying it out on patients.
I will just add on. Thanks very much, Siti and Rich, for the answers. I think I have a bit of experience, not my experience, my supervisor John Bartlett's experience in using all these neo ligaments, leads and KOs, ligaments, and he reported a lot of risk of synovitis. In my mind, I think if you want to use a neo ligament, purely a synthetic ligament, is when you're talking about return to play to sports in professional athletes. If you want to go in fast, you want to put in a neo ligament, you are in the mid-season, you want to get fast, you do that. And because we know the risk of synovitis is high, failure is high, damage is high in neo ligament. In hybrid form, I have not used it personally in my hands. I've not really come as a second position, but I think it's open field out there. I think it's open to question and to be studied further whether there's a role in it. Let's go on further. We've got a few more questions here. We got a question from Dr. Professor Nizlan asking about, do you fix your ACL graft on the tibial side on full extension or slight flexion? What is the current evidence on this? So, gentlemen, we start with on this side. Rich, what position do you fix your ACL, and why do you do that, and what's the evidence for it, and what's your and then we go on to the rest of the panel. You're muted, Rich. You're muted.
Yeah, normally I do it in 30 degrees flexion. Yeah, so then when 30 degrees, then I try to do, I push down the leg. That's when I actually tighten the implant in the over the tibial side.
Eddie?
Yeah, same 20 to 30 degree of flexions. Put a postural push the posturally and then fix it.
And
I do it at 50 degrees flexion because we want to avoid overtension, as I had always been taught by my professor. So it's like, however, I saw this one article recently with regard to the fixing it in full extension. With regard to the evidence, I think it's a little bit still not so strong. So we need more evidence with regard to that paper, because it was just like one paper that I read through recently with regard to the tensioning.
It's a very good question, Islan. I think we do it in about 80 degrees flexion. I'm trained by John Bartlett. He always does it in flexion. But I think regardless what position you fix it, if you fix it in flexion, you make sure your knee can extend on table. If your knee cannot extend on table, then you put it too tight. You fix it in extension, you make sure your knee can flex on table. If your knee, you fix in extension, you cannot flex on table, your ACL is doomed. So I think know your enemy. Whichever way you do it, you make sure that you can knee is he's able to move after the surgery. Or on table, if he's not going to move on table, he's not going to move afterwards, despite however much physio you do before rupturing the graft. Okay, the further questions. Question 7. Can we consider transportal technique as the gold standard for ACL reconstruction? What is your opinion on residual ACL laxity and all inside technique? I think we'll get one question from one person. I think Rich, you'll answer this. Transportal technique as gold standard, and what is your views on laxity due to all inside technique?
Well, I think the transporter is, I think, the best option right now compared to the transtibial, because you can actually do it anatomically. At the same time, less rotation for the knee. At the same time, what's the other question, Sirjit?
Well, what's your opinion of residual laxity in following all inside technique?
Residual laxity, well, to address that, normally, like for me, my style is, if the patient is hyperlax with his ligaments, then I normally try to put the tibial, my tunnel tibial is a little posterior, just to address a little of the hyperlaxity. So at least you've noticed, if you put a little posterior, it's not going to be that lax anymore. So
I think the question was on the residual laxity in all inside. So when you're talking about all inside, to me, I think because it may not be any aperture fixations, and it's basically swinging in the tunnel, that may be the cause of laxity in all inside. The question was all inside. Let's come to the next question. Sorry, guys, 4 more minutes to go. Can I ask this to Siti? Any reason why pivot shift may be negative in a fully torn ACL?
Actually, when I mentioned negative pivot shift in a partially torn ACL rather than fully torn ACL, so the one that I had mentioned in the chart. So we can actually find a negative pivot shift in a partially torn ACL rather than complete. Complete ACL tear, most of the time we will be able to get a positive pivot shift. Is that what I think?
Okay, thank you. I think that you've answered more or less. I will answer the simple questions. Next, we go to Eddie. How to reduce risk of arthrofibrosis if perform ACL reconstruction immediately after injury? Good question. How would you reduce knee stiffness if you do acute ACL? If you do acute ACL.
Okay, I have a very bad experience with arthrofibrosis with the patient that insists to be operated in as early as possible, and then I think the best is wait. The best thing is wait for a couple of days and then send to the physiotherapist to have put a compress, icing, and everything, and to make it cool, and then do in a couple of days after that. So if you do it, although some surgeons suggest to do it directly, but I don't think it's any point to do it in immediate fixation in ACL reconstructions. So we can wait. We can still wait.
With your point of view, what would your ideal time would be to ACL reconstruction?
Well, normally I let them settle down at least 1 week, so at least the knees settle down, it's not swelling, good range of motion is much better now. That will be the best, because you don't want it bleeding the time you do the surgery, because I'm sure if the patient will be placed in an immobilizer, it's really going to get stiff. So normally after the second day, I do range of motion right away.
For me, I think if I do acute injury, bucket handle, young patients, you want to save the meniscus, I will go in early, but I will tell the patient, mobilize them early. And in medial side injury as well, you may have to be a bit of a caution there. Let's take one last question. I think we've got 2 more minutes. I think this good question again. What valve would you consider in moderate to severe hyperlaxity individual with ACL reconstruction? Would you change or rehab to? We start with D. So you've got a hyperlax patient, unforgiving knee, going backwards 30 degrees, and can do all that orangutan sign and everything. What's your graph of choice? Eddie.
Oh, me? I use BTB.
Okay.
Yeah, I use BTB, and then do a physiotherapy first to strengthen the muscles, and then use BTB after that. Yeah.
Okay. Would your rehab change a bit in this hyperlaxity patients?
Rehab, yeah. I think I think yes, because
Would you brace them longer, or would you avoid hyperextension, or would you say don't jump too much?
well, yeah, it's not easy. Sometimes we have after operation. Sometimes the patient you have lost his hyperlaxity a bit. Sometimes if you do yeah, what I found so but BTB will be I think will be the option for
What
the
about
patients.
you, Siti? What is your choice of graph?
Mute. Still
Siti?
mute.
Okay, Rich maybe. Rich, what's the choice of
Yeah.
graph?
Well, if the patient is less than 25 at the same time has high pivoting sports, I'll do the BTB with it.
Okay.
Yeah.
I think bone-to-bone fixation in this hyperlaxity patients is way, and I think when you have hyperlaxity in primary ACLs, think of adding in ALL. Think about it. If you have a grade 3 pivot shift in this hyperlaxity patients, I would do a PTB and I will do a contralateral ligament reconstruction too. Think about primarily, because there's a talk in the afternoon. Don't go away. They talk about a bit of revision ACL, when to do, add in ALL. Don't wait it for revision too, because these are the patients, when you add in ALL, you take away 43% load from the ACL by the ALL, so that you give them the ACL the chance to survive. And I got a few more questions here, but we are running out of time. So, Didi, are we done, or can we continue? Can you please advise me, girls, in the panel? No. I think we.
It's 5 more minutes.
Oh, 5 more minutes. Okay. Okay, what is your opinion with regards to quadriceps tendon and posterior tibialis tendon as an autograft option? I think goes back to Eddie again. I think Eddie, your talk is so good. All is talk about graft options now.
Well, quadriceps tendon is good, good choice, but the disadvantages is you have to, the quadriceps muscle strength, of course, because you take a part of your quadriceps tendon. The anterotibial even, and I don't have any experience with anterotibial tendon, but autograft, yeah. But I use quad tendon only for revisions or multi-ligament injury for ACL graft. But now I do prefer peroneus longus, to do a lot of peroneus longus tendon for ACL reconstruction. It seems that it's very easy to harvest and very fast, and then the small incisions, and then it's much easier than the, and it's big tendon as well. Yeah, big tendon as well.
We'll move on to the next question from Dr. Rao. To all speakers, do you still do double bundle ACL reconstruction, and what is the indication of doing so? We start with Rich, and then we move the other way around. Rich.
Yeah, well, I hardly do double bundle unless the original one is more than 14 millimeters, which for Asians I think it's very unusual, because I just normally do a single bundle.
Eddie?
I only do the single bundle only. Yeah.
Siti?
Yeah, me too. I rarely do double bundle since the advent of non-anatomical single bundle in reconstruction. So I don't.
Me too.
Yeah.
Agree. Me too. I don't do any double bundle. If I ever need to do something more, I always go to the lateral side, and I think about ALL and think about other things to reduce the pivot shift. Okay, I think this question goes to last question to Siti from Dr. Chu. Clinically, how to quantify the pivot shift test, and how to decide whether to choose ALL reconstruction or lateral stenosis for high-grade pivot. So basically, the question is, what is a high-grade pivot shift? Then from there you decide.
So of course, you can grade it into glide. Then next is up from glide. For most gross one is clunk, and gross means very, very like jerky movement. So you can see this from the, you can see it visibly. What you can see, the jerky movement or the reduction of the tibia upon the femur. So from this, you can quantify with regard to the types, and the higher the type is, always have high index of suspicion that it is a complete tear, of which you may need to have an extra procedure besides your isolated ACL reconstruction. So of course we are talking about it. So the higher grade means usually it has been recommended that the severe grade 3 or the grade 3 gross pivot shift test would be more highly suggestive or more highly recommended to actually proceed with ALL plus the ACL reconstruction. Or
one last question. This to Eddie. I think a lot of our Indonesian colleagues and Thai colleagues are doing peroneus longus. Question. I think it's Dr. Karul, foot and ankle surgeon, is asking. He's very unhappy with you. So are you destroying the ankle function? So can you please reassure him that you're not damaging the ankle function by taking a peroneus longus? Can you convince us?
Yeah. We do also study and checking the function of the ankle and flexion and flexion of the ankle and first rate plantar flexion of the ankle, and comparing with the other sides, and looks like there's no difference with the contralateral sides. Also, I talked with Bancha about this topic, and then he said that the in short run, in short term, it looks like there is some effect, but in long term effect, it looks like there's no difference in both sides. So far we just take a peroneus longus. We don't see any effect. Yeah, maybe we have to consider in the athlete that have their ankle doing the sport with their ankle, but so far we see there's no serious complication in this kind of graph.
Do you have any concerns doing a peroneus longus and Rich?
No, I don't use the peroneus longus.
Why? Any particular reason, Rich?
Well, I don't see the need yet because I have other options. Well, if it's a really multi-ligament, maybe I can, and maybe I'll use it.
City?
Yeah. I would say I'm with Rich as well, because I don't really use peroneus longus for the same reason. My only worry is actually ankle issues.
Yeah. I think it's a big graph. I think it's a good graph, but
it's a good graph.
I think we still need to see whether the ankle, and my guru, John Bartlett, again, I have to mention him again. He's taught me something. He said, don't bugger up one joint to fix the other joint. So I'm trying to stick to the knee joint to get my tendons. Anyway, thank you very much. I think that we come to the end to our interesting session today. I would like to thank Dr. Rich Pashan, who hails from Manila, Philippines, Dr. Eddie from Indonesia, Dr. Siti, my colleague from KL. Thank you very much, and thank you everybody from joining in. Thank you very much, and have a pleasant day ahead.
Thank you.
Thank you.
Bye, Siti. Bye, Adi. Bye, Charnjit. Thank you.
Bye, Rich.
Bye, see you.
Nice to see you.
Eddie, thank you. Siti, thank you.
Thank you very much.